Welcome to the Intent Medical Group podcast. I'm your host, Dr. Sammy Khalili. I'm super excited for you to be here today to interview our new guest here, Dr. Carlos Illingworth. He's one of our critical care neurologists at NCH. I can't emphasize enough how wonderful it is to have him on the podcast. And welcome if you are a first time tuning into the podcast. We're so happy to have you here. And for my returning listeners, thank you so much for continuing to come and follow. Enjoy the show. Carlos, can't thank you enough for coming here. Welcome to the podcast. It's been a long time coming because we've been trying to get you on for a bit, and our schedules just didn't collide. The nature of you being in the ICU and me being me.
Yeah, exactly.
That's right. So, like I tell everybody when we first come on and start, discussing whatever topic that is important, I just like the audience to know you a bit and understand how you got into the field that you're in. So you originally not from here in Chicago, like myself, not either native Chicagoan. You're originally from Quito, Ecuador, or not Quito, but from Ecuador specifically.
Yes,
correct?
from Ecuador. I'm from Guayaquil.
Guayaquil. Okay, so now remind me again. That's on the coast,
Right.
right? What part? North or south?
It's south. I would say mid-south.
Mid-south. Okay. And in terms of the climate there, what is it like?
So it's very hot.
Okay.
I would say that it goes from 100 degrees to the lowest that we get is 70 degrees. And that's when we start wearing jackets and said, like, it's so cold.
I've seen that before with my Colombian family. They get cold when it's like turning, 72 in Bucaramanga. Yeah, for sure. So during that time there, you spent your whole time there, or did you move from Guayaquil to somewhere else?
No. I born there, grew up, did my everything there, all the way into med school.
Okay.
And once I finished med school, that's when I came to the U.S.
So what inspired you, being where you were, to decide to go into medicine? Was it something in your family, something about the community itself? How did that become a thing for you?
Well, not really. I think that the idea of becoming a doctor came to me when I was a little kid.
Yeah.
And my mom was kind of like, you said it, now you have to do it. No, but it kept with me all the time. And I always wanted to be a doctor, and then it became the things to follow and makes more sense. And then start doing high school, and I was really bad at math.
Mm-hmm.
But then biology and chemistry was easy to do. So in a way, I always was choosing what was easy for me. And believe it or not, this was the easy choice.
That's amazing. So is, I guess, medical school training similar in a lot of Latin American countries, in Ecuador, where you, after high school, can get in right away?
Right.
Okay, so you don't have to do an undergraduate beforehand like we do here in North America. You can, after you graduate high school, you can be accepted directly into medical school itself.
Yeah, exactly. And I even went a little bit further.
Uh-huh.
When I was on my second to last year to finish high school, that summer vacation, I did a pre-med. We call it pre-med.
Okay.
It was like a month for during in the university.
Okay.
And after that, we did exam. I passed. So for my last year of high school, I was already accepted in med school.
So you basically could take time in your summer of your grade 11 year.
Yes.
Was it just to decide whether you wanted to do medicine, or
No,
was it really?
I went for the
early acceptance. I guess.
Yeah, they do they call it the pre-university course, stuff like that. It's a course that is meant to give you all these materials and studies and stuff like that.
Mm-hmm.
Toward at the end of that, you take the entrance exam, literally, and if you pass, then you are accepted in the on the university.
That's great. That's a great opportunity, I guess. Because the other thing too, I suppose, let's say you decide that that's what you wanted to do, and then things either don't go well, or you realize you don't like it. At least early on you can move on and then spend the next year of your high school going towards a different direction. Is that
Right.
accurate? You could do that, or
You can do that for sure.
Yeah.
And there's a lot of people that do this pre-university and kind of realize that, okay, this is not gonna be for me. Or the other thing that was very common was that on the first year of med school, the class size is like 200 people. But then after the second, third year, it's only like 50. A lot of people stayed on the.
That's interesting, because that's very similar to what engineering classes do here in North America. So they just accept a bunch, but the attrition rate, meaning how many people actually get through, is high. So like you might have 150 to start, and the engineering class might graduate with 60 or 70 at the other end. So that's interesting that in medical school in Ecuador they do something similar, because it's the opposite for medicine here in North America. Yeah. It's once you get in, because it's so hard to get in, it's very hard to get someone out.
Right.
If you need to.
Exactly.
Yeah. Wow. Okay. So now you got accepted. You're going to medical school. Where in this did you say to yourself, you know what, neurology is where it's at?
That came way, way later.
Okay.
At the beginning, I was influenced pretty much by Grey's Anatomy, so I wanted to be a surgeon.
Wow. Okay. Fair.
But
yeah,
obviously, once I get to learn about medicine, the real medicine and everything like that, I kind of start shining away from being a surgeon. It was kind of not for me.
Yeah.
And then
it's not for everybody.
Right.
I 100% agree with you. It truly is not.
But then, honestly, it's because of in Ecuador, and my university has a good professors and not as good professors. So I had a great neuroanatomy teacher that he taught me a lot, and it was kind of cool. Like, so, okay, neurologist, it's cool. It's really nice to learn. But then for 4 or 5 years, almost nothing was neurology, because in Ecuador, neurology is almost like this very taboo kind of that nobody knows really how to do it. So the only ones that knows neurology are the neurologists and nobody else. So
the group never really shared well the knowledge base, or I guess didn't do a great job of trying to entice people into the field either.
Yeah, I don't think so. There was like this disconnection. Something that for me is very different that I see from med school students here that I teach, that I start teaching them how to read an MRI. For me in med school, that didn't happen only when I started doing like a radiology class, but it was like radiology 3.
Okay.
And then that's when they started showing MRI. But by then I already had done neurology, and then neurology, it was.
That's interesting. That's really interesting. So for you, training was how long then? I'm assuming 6 years, 7 years?
6 years.
6 years. Okay. So medical school training was 6 years, but you're right out of high school at that stage.
Yes.
So now I'm assuming you probably graduated somewhere around the age of 17, 18.
Yes.
Yeah. So now you're about 23.
Yeah, I graduated 24.
Yeah, 24. And then at that point, you'd say to yourself, okay, I want to be a neurologist, or no?
No. Yeah.
Okay, so what happened?
Wait.
So I'm jumping ahead.
Yeah.
So what happened? What happened?
Basically, when I finished med school, the only thing that I knew that I want for sure, it was to come to do residency in the United States.
Okay. And tell me why. Like, I'm curious.
I was in love of New York City, and I wanted to live in New York, and that was kind of like my objective. I want to move to New York.
Now, if I remember correctly, because we talked about a little bit of this before, you have family in New York. So
I have family in New York.
So you had reason to fall in love with New York. You had been there several times.
Yeah, no, like all my summer vacations, every time that I have time off and everything, I will go to New York and be there for like 2 weeks or 3 weeks and then come back. So I was always like counting the time for when my summer break was coming, so I can start getting everything ready, because I was going to spend the summer there in New York.
Okay. So then you finished medical school. You knew you wanted to do residency in the U.S., but I'm sure because most Latin American countries have some rural or component that you have to do as part of your graduation, I'm assuming, correct? So how long did you have to do that, and for where were you located?
So the first time that I came to the U.S.,
Yeah.
I did not do the rural year.
Okay.
So the reason was that if I went to directly and do like take the steps and stuff like that, and then going directly into residency here, it wouldn't really matter to do the rural year, and I could do it after I'm done with residency and all that kind of stuff. So, for example, let's say that I could have gone directly into neurology residency, became a neurologist.
Yeah.
And then if for some reason I want to go back to Ecuador to practice as a neurologist, what I would have done there is I needed to do a rural year as a neurologist.
Okay.
Which they give a little bit of advantage since you're not just a fresh graduate, but you are a specialist.
Right.
They, instead of sending you to like this little town in the middle of nowhere, they kept you in the big hospitals in the cities because they need you more there than in a small city. So that was kind of the idea of not doing it at that time, just going straight to get the steps done and try to get a residency as soon as I can.
Wow. Okay. So you did that, and you were successful. I'm sure because of your mental caliber and your studiousness. And then you got accepted into residency in neurology, or no? Is something else?
Well, before all that, I passed and everything for the USMLEs and all that. I did a couple of observerships in Mount Sinai. I did thoracic surgery observership in Mount Sinai. That was another time that I said, oh yeah, no, not for me. because there was long hours. I had to be standing there. I was not really doing anything. Obviously, I was just an observer, right? So I was just observing.
I can't emphasize how much I understand exactly what you're talking about, because the feeling among surgeons in general, I'm not necessarily in this category, but so many of my colleagues, they love to have people just stand and watch them for hours on end. Yeah. And in my mind, I guess for who I am, I'm like, I just feel that's incredibly unfair. Either they're in there doing stuff. If they want to stand and watch, great. But if they don't, I never hold it against them, because it seems ridiculous. It's like asking someone to watch paint dry in my mind, because you're watching the hole that they're operating from a distance that's probably 5 meters behind them.
Yeah, that you're literally not seeing anything.
Exactly.
And if the only way that you can see if they're actually showing on the TV.
That's right.
But if there were some surgery that they didn't have that on, so I was just seeing the back of the surgeon.
That's right. All right, so you now, again, another reason, another nail in the coffin, you're not going to be a surgeon.
Well, during that time, I was still, the idea was to become and do a general surgery residency.
Right.
I even got my first time that I applied for the match, I applied for general surgery. Okay. And I interviewed here in Chicago, actually.
Okay.
But I didn't get matched that year. And after going through that process and kind of thinking it through, that's when I start shying away from it. And then I tried to see if what else could it be that I could do. And that's when I start thinking more about things like, I always look like the mind, how they work, how the brain works. So I thought maybe psychiatry could be a good fit for me. So I started doing a couple more observerships from psychiatry as well. And the next year I applied for psychiatry. I didn't like it either.
You didn't like psychiatry either. No, that's right.
Because I started seeing more of the patient, and I like the idea of it, and I'm very respectful for what they do. But dealing with those patients is challenging.
Listen, you have to have a very special mind to be able to do that day in and day out.
Right.
And it has a very big mental load, because it's 100% cognitive, everything that you're doing. It's not easy.
Yeah, no, it's very, very hard. And you have to be on top of the of everything that happened within the unit, because I was doing observership and psychiatric units here. So there was a lot. And in New York, it's extra crazy.
Right. I can imagine.
So that was kind of started fading me away, my desire of doing neurology. So then a friend suggested me, well, why not neurology? Like, if you like the mind and stuff like that, it's neurology. It's kind of like, it's psychiatry, but we know how things are happening. In psychiatry, you just don't know.
Right.
And that was kind of interesting. And then one thing I started reading about Sigmund Freud. And one thing that clicked to me was that he's the biggest thing of psychiatry world and everything, right? But guess what? He's actually a neurologist.
No way. I don't think I realized that he is actually a neurologist.
He's a trained neurologist, and he was a neurologist that was fascinated by the psychiatric illnesses and whatnot, and he studied and he became with all this like theories and stuff like that. But he started as a neurologist, so that's kind of I took that as a sign when I saw that, and then I started applying for neurology.
Great. Okay. And so at that point in time, you applied for neurology, and if I'm not mistaken, you got accepted to go to Drexel.
I got accepted to
Drexel in Philadelphia.
Right.
And oddly enough, to know that the world is a very small place, you got connected with my second cousin, who was your junior or senior?
At that time, he's my senior.
He was your senior resident.
Yes, senior resident.
Which is incredible to me that how small the world is. But when you work in medicine, it can get small.
It can get small, yeah.
It can get very small. So then now you're in neurology and you're doing everything and you're enjoying it now. You really, I think you find your passion. Am I correct?
No, yeah, I loved it. That's one thing that when I started doing neurology as a second year and really feeling it and doing all the things that and somewhat I didn't do when I was in med school, or the exposure that I had. Sometimes I felt like I was at the level of a med student, even whenever I have a PAA2, that as a PAA2, I will have some med student that they know stuff that I didn't. I was like, okay, I need to get myself put together. But everything that I was learning, like, again, learning about MRIs, like how to read them, knowing about like doing LPs, doing...
and for the audience, LPs are lumbar punctures.
Lumbar punctures, exactly.
Yeah.
Or all the stroke component of neurology. All that was such a refresher in a way that it break through the idea that I had of what neurology is,
right,
versus what neurology actually is.
Right.
And I loved it. Like, I think that I couldn't be happier, and I really thank God that he made me walk through this path, not really going with the flow, basically. Right. I was just going with the flow, I landed there.
Yeah, but I mean, that just shows that you were, like, at least for yourself, you were open to what life was giving you at that moment in time. And that's a not everyone's always open to that kind of thing. And that's, I think, a testament to your personality and being able to move and be agile with what the changes were, especially like from coming from a different country, then having the idea of being in a different city and then different specialties and all those things. But you pivoted very, very relatively smoothly. You were able to just kind of decide for yourself what you wanted. That's pretty great. Like, not everyone can do that. I think that it'd be great for young people to know you're allowed to do that.
Right.
Right. Yeah. You're allowed to do that.
And that's something that, especially for me, that I did med school directly from high school. I felt like I never had that time to stop and think about what I really like or what I actually want to do. Again, like when I started this med school, I was just thinking about how cool it is to be a doctor from Grey's Anatomy or like House. That was the other one on my time. Like, everybody want to be House. So that was kind of like the like.
That's right. House was popular at that time. Yeah, that's right.
And just to get it and have it at time. And while I was in New York, like I kind of have that break between being in a med school kind of path and into waiting for actually becoming a doctor. It allowed me a lot to think about what I want to do and how things, how my life can look like.
Yeah. So now at this point, you finished neurology and you decide you wanted to be not specifically in any specific area like functional or something else. You decide I want to be in neurocritical care, right?
Yes.
That's your area of expertise. What decided that you wanted to be there and not, let's say, some other element of neurology? Because I what I've learned with talking with so many of your colleagues in neurology is that there are so many different subspecialties. No one can be an expert in any single one. So you have an opportunity to jump into a bunch of different buckets and become an expert in one thing. So why this one?
During my internship year, I really liked the MICU rotation. That was kind of the rotation that I liked the most. So,
and by the way, NICU,
MICU, medicine ICU.
Medicine ICU, okay.
So when in the neurology residency, you have to do your first year, it's internal medicine.
Yeah.
So when I was doing my intern year, my best time ever was in the ICU. I really enjoy it. So I kind of kept that in the back of my mind when I was going into neurology. But then when I started doing neurology that I really like, I started doing more like, seeing more like the neuro ICU part of it.
Right.
And I was kind of like, oh, this is even better. Like I like both things that I enjoy the most. I can combine it. And then that's how I started looking more into doing more critical care.
Wow, that's great. And so then that's where you settled in. And then how did you end up in our orbit with intent, like to figure out like coming over to Chicago? Because as you said, New York was your place. That's the place you wanted to be, right?
Yeah. Well, I lived in New York, so I think that I had my cycle there.
Okay.
I completed, and I think for now it's okay to experiencing more.
Right.
I'm being lucky enough that I basically have lived in all major cities in the U.S.
Okay.
And I really enjoy that. I feel like that's one of my passions is to travel a lot. So
that I've noticed. I've seen, yeah.
And I like to visit new places, and I've been lucky enough to live through all that. So I'm pretty happy, and Chicago has been like an amazing surprise. Completely overperformed on my expectations through the roof. Like if anything, I would say it's the only city in the U.S. that I can tell that it's fun to stay this summer.
This is true. It is a fun place. There's very few places as fun as Chicago is in the
that
summer,
you want to actually stay in here. Like you spend the summer because it's like a lot of fun, a lot of things happen. If some artist is doing a concert, it's gonna stop in Chicago. Is something happening? Like a tour or something is stopping in Chicago, so you're not gonna miss it.
Yep.
So it's a really, really cool city.
That's awesome.
So I came here because my partner works at Rush.
No way.
So I was kind of looking for a job here, and then he got an email from Reham asking him to see if he had a contact to get he was looking for an MS specialist. So and he just replied to him and said, hey, I don't know, I don't have right now any MS doctor that is looking for, but I have one that is looking for a neurocritical care position. Do you have any? And he replied, yes, I have.
That's how it happened. Wow, that's amazing.
And then we got in contact each other, and then
That's amazing. And just so you guys know, Rehan is Dr. Rehan Sajjad, who's our chief of neurology here with IMG that we work with. He's awesome as well.
Yeah, I know. As soon as I met him, I said, like, I want to work with him.
Yeah.
He's a really cool guy. I think that our first interview, we connect a lot. He was honestly, everything that he was saying about the program and about what his vision of it was exactly what I want to hear. It was kind of like, I felt like, are you kidding me? Like, where's the camera? Like, this must be something. What's the catch? No, amazing. So it took me, I think like we had our first email, maybe late May. I was interviewing early early July. No, maybe or late July or late June. And by mid-July, I already has signed my intent letter of they're coming here.
That's awesome. Well, we've been blessed to have you. We know that for sure. And I think one of the big things that I wanted to talk to you about, because I know it's a passion of yours, is because so much of what you deal with is stroke. And we talked a little bit about with one of your colleagues, Julie, Dr. Hall, there before, and she gave some great advice to everybody in terms of what to do when you're encountering a stroke. But the big question that so much of the world really wants to do, especially like younger people and whatnot, is how can we prevent it? What can we do to not get to the point where I'm worried about thinking about BFAST and all these things that go along with it, to say, okay, what can I do now I'm 43, my wife is 42, my friends are all around that age, friends who are in your mid 30s, probably like yourself. What can we do that is even stroke, like to help prevent against stroke, and also what is stroke preventative specific? What can you tell us? What kind of nuggets do you have?
The most common risk factors for stroke are high blood pressure, high blood sugar, and high blood cholesterol.
Okay.
So those are the main thing.
Let's say them again: high blood pressure, high blood sugar, and high cholesterol. So those are the big three risk factors.
The big three
for having a stroke.
Which
oddly enough is probably similar risk factors for having a heart attack.
Exactly.
Yeah,
so
okay.
The same thing. Imagine that the same way that the arteries in the heart get blocked and you have a heart attack, same thing going to happen in your heart and your brain. You're going to have a plaque that is created by the excess of fat. That the same way that it creates around the heart, it can create around the arteries inside of your brain. Sugar affects the blood vessels of any part actually of of your body. So it affects the same way that affected in the heart, affected in the brain. And having high blood pressure is a constant pounding on those arteries. It damages the arteries themselves. So the big three. If you want to add smoking cigarette to it, I think that will be the fourth one.
Yes, well,
for sure.
Yes,
but
for anyone who doesn't know this already, smoking cigarettes is not good for your health.
Yes, it's not good.
Period.
It can you can have strokes, heart attack,
Cancers,
lung cancer,
everything. Ages you worse.
It
horrible
affects
voice.
your whole body.
Yeah.
So, and the thing about those risk factors is that you can actually change it even before you need to have a pill for it.
Okay.
So if you want to lower your cholesterol, if you want to lower your sugar, you can also, and even you lower your blood pressure, you can do diet and you can do exercise for that.
Now, is there specific kinds of diets or specific kinds of exercise that are more helpful here? Because I know there's a lot, like you see this on social media. There's a huge amount of people say, do these three things and guaranteed to do this. But yeah, I see all what I label as nonsense, which is you'll hear the automated AI voice come in and say, if you just add 3 tablespoons of cumin, a cucumber, eye of newt, and things like that, and you have a drink, it'll solve your problems. I know nothing is that simple.
No.
So what do you say?
What I would say is that it's about balance.
Okay.
It's about to know that things has to have a limit. They're not to exceed, especially in eating sugary food or too much of fried stuff. That could be very detrimental to your health. There's the Mayo Clinic came up with a good paper showing that the Mediterranean diet, it has a lot of neuroprotective effects to your brain.
Okay.
And what is a Mediterranean diet? It's a very, very simple thing to think about it. So they do a lot of grains, greens. They have good fat, which will be the olive oil.
Okay.
They eat a lot of fish, and they don't eat much of red meat, and they don't do much sweet. So if there's this really nice pyramid that they tell you which foods you can take, you can eat every day. So they said, for example, every day you can have fruits, you can eat greens, vegetables. That's something that you should have it in every meal.
Okay.
Then in
with the goal of being neuroprotective.
Neuroprotective, yes. So and to follow this diet, like the Mediterranean diet. Then the other one will be if you are like if you eat fish, you can eat fish like maybe 2-3 times a week. Use a lot of olive oil for that. You can use avocados also, a good source of giving that type of fat, that omega-3 fat. Then you have the ones that you maybe only eat once a week, which will be your red meat, you like your sugary, like let's say like a cupcake, or like if you want to have a soda, you can still drink it, but if you can only do it like once a week.
Once a week. Interesting. So in that diet, I mean, eating fruits and eating dark leafy greens is what you were saying,
right?
Or just greens in general.
Greens in general, but for example, spinach is very important, and arugula is also.
Arugula is also a good one. Okay, and what about like green beans and things like that?
In green beans, also like lentils. Are also like the oatmeal. It's very good.
Okay. So eat that. Is there specific fruits that they recommend, or is it ones that have higher fiber or water content?
The ones that are the ones fruit that have shown more neuroprotective are the berries. The berries are the ones that have shown.
Okay.
Especially things like blueberries are really good for as a neuroprotective.
So berries, blueberries, blackberries, raspberries, strawberries.
Yes.
I'm trying to think of any other good ones that we can get around here that are tasty. But yeah, so those ones are good. Okay, but they only recommend eating red meat once a week.
Yes.
Wow, that's new. Well, news to me. I did not know that.
Yeah. So only once a week, because I think that the fat that it's in the steaks usually is not a lean fat. It's not. It's more saturated type of fat.
So it's based on more the fat and less the protein that's in the meat.
Yes, because they all recommend to eat more lean proteins.
Lean proteins. And to them, lean proteins would be, I guess, leaner meats.
Yes, like for example,
chicken.
Chicken is also that you can have once a day, every day. You can eat that between fish.
Yeah.
Also, turkey. It's another alternative as well.
Okay. Wow. Okay. Because so much of dietary things that you hear about on a regular basis pertain to one specific thing. So this is what we're talking about for being neuroprotective. But I also keep hearing about in diets about protein intake and how important that is, which was something 20 years ago wasn't emphasized all that much. So I'm curious, to still be neuroprotective, is there a protein number that they also tether to, or no, not really? Not really any information about that yet.
I don't think there is a specific protein requirement that they suggest specifically. The neuroprotective effect that they are alluding to is that it helps to reduce the oxidation process.
Okay.
It helps to reduce inflammation. So when you use or eat, I would say, like these berries. These berries has this antioxidant in themselves, so they help you to mitigate all this chronic inflammation that we may have in our brain that could potentially lead to any more neurodegenerative disease later on.
So when we're talking about increasing the amount of, I guess you're talking about free radical antioxidants essentially from in the berries, and you're trying to increase that so that it's neuroprotective. It's being neuroprotective against both stroke and neurodegenerative disease, or is it just mainly for neurodegenerative disease in this case? The reason I'm asking is it's more genuinely, I'm curious. Do we know that the degree of inflammation you have also increases the amount of stroke potential you have.
I think it's both. I
Both,
think
okay.
it's both because it is part. Going back to when I told you before about
Yep.
the blood vessels, they get damaged with high blood sugar. They get damaged with high blood pressure. If you see it on the microscope, you will see local inflammation because of that, of those external factors.
Mm-hmm.
So if you have something that is helping to have a more remodeling and helping to not to get as much damage, those blood vessels will continue bringing the oxygen those cells or those connection to cells needs to thrive.
Mm-hmm.
So yes, we have seen it for patients with dementia, but also there's a room to think about that could be helpful to be true for decreased risk of Parkinson's disease, decrease the risk of having a stroke in the future, decrease the risk of having a hemorrhage in the future. Those are the things that overall will make you also feel better and make you have a little more like a healthy lifestyle.
Yeah. Oh, wow. Okay. Is there anything else in the Mediterranean diet that you should be doing? Like, besides what you're eating, do they talk about frequency or size of meals or how much or things like that also are helpful and neuroprotective, or is it more about the content?
I don't know if they did specifically like this specific diet.
Right.
The one thing that they were mentioned is that it should be tailored for the needs
Individual.
of the patient, especially because the idea of having this type of diet is not for you to only eat this and this is the only way that you're gonna be able to achieve this protection. It was more for this is what we recommend and apply it to your normal life. How can you, if you see this pyramid, you think about how can I make that my regular life without feeling that I'm taking away something from that I like to do, and finding that balance. I think that's important because some people will think that, oh, I need to be diet, so I'm just gonna start eating lettuce and that's it.
Yeah.
And that never
won't work.
That will never work.
That
never work because you are there miserable.
Yeah.
You're hungry. You're not, and and your gut is trying to eat yourself, so you're gonna start having other issues. So you're gonna feel bad, and at the end of the day, you will say that it didn't work, so I'm gonna go back to eat my McDonald's. And then that's what happened. Then you go back to the stream. So you need to find your middle. That it's okay if you want to have a burger here and there. Nobody should say like, oh, you shouldn't have it. But at the same time, if you have a good, healthier way of life and you eat healthy throughout the week, you can always have those reward food.
Yeah. Okay. So we talked about diet and how the importance of it, and then of course the Mediterranean diet being part of it. Obviously, as the complement of this is exercise. That definitely is important. How much and what specifically do they recommend for exercise to be neuroprotective?
So at the very least, you should be doing 30 minutes of exercise 3 times a week.
And so what qualifies as exercise? Meaning, am I just increasing my heart rate? Am I doing muscular workout? What am I doing?
It could be a combination of both.
Okay.
Usually, the heart rate means it's just to make it a more like aerobic type of exercise,
right?
Which it will be okay if you want to jog for 30 minutes or that will be good enough. But doing weights, it's also another type of exercise, and not necessarily you don't have to go to like 120. If you can do an exercise like at home with light weights and stuff like that, even that type of exercise is good. And at least if you do 30 minutes of that 3 times a week, it gives you some protection. I mean, it's not gonna make you like
30
super
minutes,
buff or anything like that.
Yeah, but 30 minutes just 3 times a week. which really
The very least. It's
Yeah.
a very least.
you're not asking much
No.
for that in general. So that's actually very achievable for, I would say, the majority of humanity. They should
Right.
be able to do
So,
that.
for example, this is a recommendation that we always give a patient that has Parkinson's disease.
Yeah.
To get your 30 minutes, it's so important. And 30 minutes means just walking around, like moving, because when you have Parkinson's, you tend to slow down, you tend to stop moving.
Right.
And the more you don't move, the less you're gonna move. So you need to encourage these people to move their muscle, to stretch, even doing stretching. Also, the other thing that is helpful, doing meditation, mindfulness, also that calms your stress and helps you also to not to be in this hyper state that sometimes we are put there due to our
Mm-hmm.
duties of living.
Mm-hmm.
So that's also important to relax, to get a good sleep.
Sleep is so important. And we've kind of talked about that on other episodes too, but it's tremendously important for sure. Meditation is a great thing to have for people to have, but I wonder, do people know how to do it? Like, do you know how to do it?
I learned a
I'm
little
curious.
bit. And I had a co-resident that he was really good, and he was the most zen resident ever. Everybody loved him. Like there was nothing that he will get upset about, and like he was so good.
That's awesome.
And when he was a third year or fourth year, he started doing like a meditation classes for us. So we will go there. So and it's somewhat pretty much simple. Like the idea is that you need to be present in the moment. So when you're meditating, it's about the now.
Mm-hmm.
It's not about what happened, what just happened. It's not about what is going to happen. It's about for you to put your mind in what is happening in right now.
Mm-hmm.
And it's a little bit challenging if you try to, because
That's why I asked the question.
right. Once you start like close your eyes and start to just try to think and not think. It's hard to say like not to think, but at the same time, it's not to start thinking of ahead. Like you just need to live in the moment. And that's what it makes the mindfulness and the meditation is kind of like to makes you realize that life is now.
Mm-hmm.
Whatever passed or is already in the past. In the future, we don't know. So the only thing that we have for sure is what is happening right now.
Right. Wow. Okay. Well, I think that's something a topic I'm gonna have to explore for the future, because it's something I just realized that we talk about it like, so yeah, just go meditate. But what does that mean? Do I just sit there and go, you know, that's not what's gonna work. So, oh, that's great. All right. It's as part of this question about like the things that are protective that we can do overall. You mentioned lifestyle. We talked a lot about diet. Is there anything else that you would also recommend, like that we would take, or a supplement or whatnot, that is generally beneficial, that is generally not super harmful, what kind of side effect or whatnot that might be helpful? The answer can be no. I'm just curious.
No, I mean there are good supplements there, and depending on what you need, there are a bunch of multivitamins, things that I think that are very helpful to have. It's like have magnesium supplementation, vitamin C is a good supplementation, vitamin D, as David, it's a very good one to supplement, because those are vitamins that tends to the magnesium is not a vitamin, but minerals as well that tend to get lower. And if we take once in a while a little bit of those supplements, it's gonna boost our immune system, boost our nervous system, and boost our ability to our bones and grow. And especially here in Chicago, where we spend half of the year covered. I would say probably we have like a epidemic of people with low vitamin D.
I'm not sure what the percentage is across North America, but the percentage is very high. If I'm not mistaken, and please no one quote me if they hear this, I have to look it up again, but the percentage of people in North America that have vitamin D deficiency is well above 50%.
Yeah.
I'm just, I can't remember what it is. I think the number is 70, but I don't.
No, it's very high.
It's very, very
high.
high.
It's very high.
It's recommended that everyone should be taking vitamin D.
Yeah, and it's very high, and it's linked to autoimmune diseases.
A huge amount of it. Yes, that's correct. That's correct. All right. Well, this is great information for people to use. So things I've learned so far from this is Mediterranean diet, I think is a very helpful thing.
Yes.
And what that means being eating, obviously, good fruits and vegetables, but specifically more berries. Other fruits are good too, but
I would say that if you want to take home the berries, the olive oil,
because of the omega-3s that are heavy in it.
Always avocados are really good.
Avocados are very strong for it.
And fish, salmon is good.
Again, because of the omega-3 and protein that you're getting with it.
Yes, that the protein is.
And the other big thing, because that was news to me, was once a week with red meat.
Yes.
Once a week with red meat. To be neuroprotective, we're talking about. If you're training for something crazy, then, I mean, that's different. You have to get a whole lot of protein in other ways.
Right. But that's a different story.
But if you're trying to protect yourself from what you're saying, from stroke and from neurodegenerative diseases, that's what you have to do. Okay. Exercising at minimum 30 minutes 3 times a week.
Yes.
But that's it. That's all. That's enough.
That's enough. I mean, I honestly,
more is better.
Yeah. But if you only have those 30 minutes, I mean, it's doable. Yep. That's the point that I want the people to take home is that you don't have to be in a gym. You don't have to have have the Peloton at home.
That's right.
Or you don't have to do anything like major. That is the one thing that makes people not want to do it in the first place. Like, oh no, because I don't have this, or it's because I don't have that. It can be simple. You can just put a mat on the floor and then do some stretching. Again, some mindfulness and like push-ups, stuff like that, and that's it. Do it for 30 minutes, 3 times a week.
Wow. Okay. And then lastly, supplements, but not taking supplements, but specific ones just for making sure that you're not deficient in vitamin D, magnesium you mentioned, and I think you said vitamin C?
Vitamin C.
Those are the big ones.
Yeah. So a
general multivitamin should cover you for most of these things.
I would encourage that to ask your primary care physician to check your levels. And whenever you do, you get your checkup, and then
that's a very good thing to say. Just go check these levels on everybody, on yourself, to see where you're sitting. So if you already know that you're doing the right thing, then you're okay. Yeah. In the world we're living in today, and as you know, there's been a huge explosion. I'm not sure because you graduated. I can't remember how many years ago, but for us, for me, I've been out now of medical school since 2009, residency since 2000, fellowship since 2015. All the medications of GLP-1s came out several years after that. So this is a completely new technology in general for me in its entirety. So I've learned over the last year more information about it, but only to the degree that I needed to for our management of our specialty thus far. And I've been actively trying to learn more because I know that so many people and so much of the population now are consuming it. My question was, what information do you have whether GLP-1s have any kind of benefit, harm, et cetera, for neurology in general? Is there something that we can look to, or is there stuff that being investigated? What info do you have?
Well, so concrete evidence so far we don't have just yet, because like you mentioned, this is such a brand new medication that is taking everybody by storm, and everybody is trying to find what is actually good for. But there has been a couple studies that has been showed that some neuroprotection from the GLP-1s. There's a meta-analysis from Ireland. They did a retrospective study with 26 studies, and they found that the people that they had diabetes and were using GLP-1 has a lower incidence of dementia.
Interesting.
Then was another American study in their case, they just did like kind of like a chart review.
Okay.
They also, the criteria was to look for people with diabetes that has dementia who is taking this medication. And they also found in their study that the people that was taking GLP-1 had lower incidence of developing dementia in those cases.
Now, I'm going to put a caveat in here for a second for the public, because I don't want everyone to kind of come away from this saying that, oh, I should be on a GLP-1 to lower my dementia risk. That's not what you're saying.
No,
That's not what you're saying here at
no.
all. Scientifically speaking, when we're talking about this, and you can correct me, the meta-analysis is a scientific way to look at several different papers at once, compiling their outcomes and getting some kind of information from it. But that is only going to be as good as what the papers that are going to go in it.
Right.
And if I'm not mistaken, probably most of those papers are retrospective in nature.
Yeah, everything is retrospective.
Yeah,
nothing is to the future. Nothing is prospective.
So when we talk retrospective, we're talking about papers that only looked back in the past of, these people happen to get it. This is what they look like. Mm-hmm. And that's kind of what it is. What you're saying needs to happen. Why don't you tell us what needs to happen next?
Right. And also for people to know. And because of a retrospective study, because it's something that the investigator did not design versus they are just trying to make sense of the information that is out there,
mm-hmm.
there's a lot of variables that can be between papers, right?
Mm-hmm.
One paper could have defined dementia the one way versus another paper maybe define it differently. The other thing that was also they point out on this argument was that most of these papers, they were commenting about dementia as a side effect or something like kind of like something that they just found or they just add as just to put more to make it more robust their study.
Right.
But they were actually studying something else. So they was not meant for them to get that information. So the studies were not designed whatsoever to make that statement that this investigator found.
So what the studies really have told us, there's a clue there.
Right.
That there may be a link and there may be some help, but we need a lot more info.
We need a lot more info. We
Right.
do need to do a double-blind study and follow these patients now to the future. So now that we have designed the study and we know we're going to have a baseline, we know what we're going to look for, we can study these populations, how they are looking in 6 months, 2 years, 1 year, 10 years from now, and then actually get a real recommendation. Because the other thing that we need to know is okay, we are looking for what the good that it does, but we also have to look for
the bad,
the possible harm.
Yeah, yes. And I guess the other piece of it too is that there's all questions that come along with this. Is it the same dose that you need? Is it a different dose that you need? Do you need to be taking the same dose to get weight loss to get the same thing? If this is true, so there's too many questions before you can kind of jump in and say, "Oh, go ahead and take this because it's going to protect you against dementia."
Right. That's the other studies that are showing for protection. It's also for Parkinson's disease.
Okay.
That one, it was, I believe, from France. So they had 156 patients, and they actually did a double-blinded study.
So this one was the first kind of double-blinded look.
I don't know if this is the first, but
this is one of the ones, for at least one of the first I'm hearing about. We'll say it that way.
But double-blinded, but very small sample, and they did it in a couple centers in France. And what they found, the way that they designed this study was that they enrolled these patients. They scored them with the Parkinson's disease scale part 3. So they gave a score, and then the group, they divided in half, right? Half of them got the GLP-1 medication, and the other half got placebo. But they were injecting it and having think that they are getting the medication.
Right.
Toward the end of the year, at the 12th month, they redo the scores,
Mm-hmm.
and the people that was taking placebo, the scores went higher 3 points
Mm-hmm.
versus the one that was taking the GLP-1. They stayed stable.
And this one was targeted specifically for Parkinson's,
It
right?
was
Like they,
for
that was
Parkinson's.
their
Yeah.
endpoint. That was what they were looking
Right,
for,
because
right?
these doctors in France, they have the theory that diabetes has a link with Parkinson's disease, and they wanted to see if there's there was something there that they can prevent.
Okay. So that's interesting and really great information that they got now. So now the next step for this, they have to expand it to see, is this generalizable?
Exactly. So they need to make now a big sample, like multi-center, hopefully even doing in multiple countries at the same time.
Thousands of people need to be enrolled.
Yeah,
yes.
thousands of people need to be involved. But the thing is, it is promising, right? Because it gives you an idea. It gives you, maybe we have something here that might be helpful. And the more that we learn about these medications, because going back to what you said, this is brand new.
Yeah.
For everybody, not only like the general population, but for doctors.
For all the medical professionals, for sure.
It has been a game changer, and it has changed the landscape of how weight loss should work.
And be managed. Yeah.
Be managed, and how much you're gonna need to improve your quality of life.
Yeah.
And it's so available, like literally you can buy it from an app or from your phone. So it's definitely something that we need to pay attention.
Yeah. Well, this is great information. I think that's something that the public now can kind of go look into and see what they think. And I'm looking forward to seeing what else comes out, because I'm sure there's going to be more things that we're going to be looking at with regards to what GLP-1s are helpful for or not. And then the other, you hear a lot of things about peptides in general, and I'm sure there's other ones that are going to come up that we're going to hear about.
Yeah, I think so too. This is kind of remind me of when the immunoclonal therapy started showing up. That start with one that this is promising, and then once we learn that there's this path that we can block, and that we can actually block so specifically that we can start helping specific diseases, that therapy is expanded. Right now that I remember when I was in med school, it was like 5 that you can memorize them. Now I don't think that
there's an endless supply.
So much
that
it's impossible to keep up of everything out there. If anything, it changed neurology as well.
It definitely did.
Because of neurology before that, it was almost like you will go to your clinic and you have.
It's a lot of diagnosis and no treatment,
exactly.
right?
You have this.
And that was the joke when we were going through medical school, was that neurology, you must just like diagnosing and not treating a whole lot, because there were treatments available. You had seizure medications and this kind of thing,
but it was more to manage symptoms.
Exactly. That's
nothing to
stop the problem.
Yeah, to stop the problem, to try to prevent it.
Yeah.
And that's something that at least a lot of medication in the MS world has happened. There's a lot of medication for myasthenia gravis that they were not there before. It's a very exciting time to be a neurologist.
Wow. Carlos, there's so many other things I could ask you about pertaining to prevention and diet, and I'm sure we'll save it for a different day. One of those questions that popped in my head as we were talking, I was like, man, I need to ask you about creatine, because I keep hearing about this being a neuroprotective thing and whatnot. But we should save that one for another day, because I think you and I both have had long weeks, and it's good to break from this, and the World Cup is on, so we need to go.
Exactly.
We need to go watch those games.
Go Ecuador.
But listen, thank you so much for being on here. This is fantastic. I can't thank you enough. It's a pleasure as always to hang out with you.
Yeah, no, of course. Thank you for having me. I mean, I really enjoy it.
Yeah.
You are a great interviewer, so I enjoy it.
I appreciate that.
Thank you.
Thank you so much for tuning in to the podcast here this week. I'm so excited that you've been continuing to learn and see what we have to offer here at Intent and learn about more topics. On that note, Comment on the podcast below and let us know what you'd like to hear about. We are more than happy to interview anyone you might be interested in or talk about topics that you may want to learn more about. Thanks again, and we'll see you next time.